We are live. Bismillah Rahman Rahim. Assalamu alaikum. Welcome to the third session of day 2 of Pakistan Endocrine Society. Our topic is obesity, a new buzzword. I'm Dr. Kiran Choudhry. I'll be moderating this session. We have tried to approach this topic from a novel angle, and we hope that you find our topics as exciting as we do. Our chairperson for the session is Dr. Tabinda Dugal. She is very well known to all of us. She's the consultant endocrinologist at Royal Cornwall Hospital in UK, and her interests are gender medicine, women's health, obesity, and bariatric surgery. We also have 4 panelists today. Dr. Maleeha Hameed, who is an associate professor of medicine and endocrine at Lahore General Hospital. Dr. Urooj Lal, an assistant professor of endocrine at JPMC with special interest in meta-obesity and pituitary disorders. Dr. Amina Umer, assistant professor at Allama Iqbal Medical College, and Dr. Zareen Kiran, an assistant professor at National Institute of Diabetes and Endocrinology at Dow University of Health Sciences, Karachi. We have 2 great speakers who have kindly agreed to present in our session. And I will pass the mic on to Dr. Dugal so she can introduce Dr. Naveed Sattar for the first session.
Thank you very much, Kiran. And
hello, assalamu alaikum.
It's a really great pleasure.
Sorry for being late.
It's really a great pleasure to introduce Dr. Naveed Sattar, and I've heard him talk in many meetings, and always very impressive presentations. So I'll give you a brief biography and what he does, and I think it would take more than like 5 minutes to introduce him, but I'll try be as brief as possible. So he's a graduate of University of Glasgow in 1990, and he got his PhD from the same university in 1998. He's a professor of metabolic medicine at Institute of Cardiovascular and Medical Sciences, Glasgow Royal Infirmary at this point in time. And he's also fellow of Royal College of Pathology and fellow of College of Physicians and Surgeons in Glasgow. He sits on several task forces and committees. He was with the European Society of Cardiology Task Force and later became the chairman in 2019 for diabetes, pre-diabetes, and cardiovascular prevention guidelines. Currently, he's running several drug and lifestyle trials for cardiovascular and diabetes research. He's on the editorial board of many journals, and of those, a few are BMC and associate editor of Circulation. He's got about 800 papers under his belt, and he's amongst the top 1% cited clinical academics. So just to name a few things that he does, and I'll never forget how he says that the difference between the English tea and the Desi tea, you know, how you go into houses and you get offered a cup of tea, and then along come samosas and along come a little bit of mithai. And so if tea means tea, and I think that's one of the things that brings us obesity, but that's his topic of today is, you know, what's different about obesity in the subcontinent? How can we change it? So over to you, Naveed Sattar, please. You have to unmute yourself. Yeah.
Yeah, no, thank you very much. I'll share my screen if that's okay. Okay. I hope can you see all of that? I hope you can. Just see, yeah. I'll assume it. Shout if you don't hear me or you can't see my. Yeah. So you've asked me to talk about what's unique about South Asian obesity and can we change it? And here is a picture of Glasgow. I'll start off. It's the university. 1451 is it's the 4th oldest university in the United Kingdom. So. These are my disclosures. I thought I'd start off with Glasgow. The reason, I mean, I really love Glasgow because the people are really very caring and generous, and you know, there's an honesty about Glaswegian people or people from Glasgow that really endears you to them. They're not, you know, they're not pretentious. They just are what they are, and. Also, the other reason I love Glasgow is because within you know 45 minutes you can climb big hills and mountains. This is not a big hill. This is 45 minutes up, and you can see in the distance something called Loch Katrine. It's a lake with so it's a beautiful view. So if you ever come, you know, once we get past this pandemic and in a year or so time, and you're able to travel put Glasgow on your list, and Edinburgh's not too far away as well, but it's not as good as Glasgow. Well, I would say that. So top line on, I'm going to talk in more about a context of diabetes, because, you know, South Asians and Pakistanis and, you know, South Asians have a higher risk of diabetes. But in terms of what our risk for diabetes is age, you know, our body makeup, genes, whether males more than females, ethnicity, South Asian being one of them, sets your susceptibility, your gradient to when you're going to develop a certain disease. And weight gain is what pulls a trigger to diabetes. And it's, you know, there's probably a threshold which varies with age. And really the concept that we've worked on in Glasgow, which I'll show you in the next few slides, is that type 2 diabetes in most people is due to ectopic fat and fuel, and possibly fluid, more so in whites than South Asians. And these things link to cardiovascular risk factors, lipids, blood pressure, and cardiorenal complications. And the reality is South Asians, this is not rocket science, it's actually very easy. South Asians have smaller engines, i.e. we have tend to have smaller muscle mass. And we also, for some reason, have a smaller safe fuel depot, and I'm not sure whether that's subcutaneous, but for a lower weight gain, we start to put fuel or excess fat into the wrong places sooner, i.e. into the liver. That gives you a high liver fat, and I'll show you some evidence emerging for that. Higher triglyceride levels, which I think you're all familiar with. And there are a number of other signals that tells us that South Asians, for a given BMI, are putting more fat centrally and probably at the same time into ectopic tissues like the liver and possibly the pancreas, which then leads to faster diabetes at a lower BMI. And I think that's what we're familiar with. So this is a paper I wrote with Jason Gill a few years ago. So when you spill over fat, the fat spillover comes and it's linked to your age. The younger you are, the more you're able to put fat in safe tissues. Genes, you know, family history of diabetes means that you're not able to store fat safely. Women store fat more safely than men and have a low risk of diabetes in middle age in nearly every ethnicity. It's something we published. And ethnicity and South Asians are a group that do spill fat over. I'm not going to show you the exact data, but we've got beautiful data now from Glasgow. You know, even with a small amount of weight gain, South Asians' fat cells are already full and they're putting the fat somewhere else. And it's probably what happens is that sooner weight, a lower weight, some of that fat, because it can't get stored in safe fat tissue, it goes into the liver, and the liver then exports that fat also in the form of triglyceride or triglyceride-rich lipoproteins. As triglyceride goes up, HDL goes down. And the classic phenotype in South Asians in terms of lipids is high triglyceride, low HDL, and it's linked to liver fat. The fat probably also goes into muscle. It goes probably around blood vessels. It links to higher blood pressure. And I'm not sure about the blood pressure. It may be that it's higher at a lower BMI and other aspects. And then eventually, if you put enough fat on, the fat will also get into the pancreas, and the pancreas will start to make less insulin because the beta cells are impaired. And then the combination of beta cell dysfunction and greater insulin resistance due to all of this excess fat can eventually lead to hyperglycemia when you relative beta cell failure. And at that point, you have diabetes. And I think that's what's happening faster in South Asians. So if you want to read a paper about ectopic fat and the evidence for the kind of ectopic fat hypothesis, I would refer you to this paper that Roy Taylor was the lead, Professor Roy Taylor from Newcastle. Ahmed Al-Marbaha and myself wrote this in Lancet Diabetes last year. And it's dead easy. And I think it fits with what I'm thinking about what's happening in South Asians. For a positive calorie balance, on top of pre-existing muscle insulin resistance, which South Asians may have more of, they put more, and also for an impaired ability to store fat safely, which South Asians may also have an impaired ability. So at a lower BMI, this positive caloric balance goes into the liver. You get liver fat, which then means that the liver becomes resistant to insulin, continues to produce sugar when glucose when you don't need it. At the same time, that VLDL triglyceride is exported to the islet triglycerides that impairs beta cell function, and eventually the combination of peripheral insulin resistance, impaired beta cell function leads to high sugar levels. And that's what happens. And we've shown that actually that's what happens. And we've shown that we reverse that as well. I'll show you a slide in due course. Just in white, if you take you to white individuals, so this is a study in the UK Biobank, which is predominantly in white. It's a paper we published again last year in Diabetes Care. If you look at this is predominantly white, it's 500,000 people. And people with pre-diabetes compared to normal. So remember, at pre-diabetes, the sugars are starting to climb with the, just before frank diabetes, as you know. But the characteristics of those people compared to normal glycemic individuals, they were about 3 units higher. But in white individuals, they were already 6 to 10 kilograms heavier, i.e., they're starting to put fat in the wrong places. The blood pressure was 6 millimeters mercury higher. The cholesterol to HDL ratio was higher, consistent with higher triglyceride, lower HDL. And these things happened before the sugar started to go up into the sort of diabetes range. So the cardiovascular risk in pre-diabetes is linked to the usual risk factors. It's not linked to the sugar level at that level. It's linked to the cardiovascular risk, obesity, hypertension, or sort of high blood pressure and abnormal lipids. In the direct study, this is predominantly in whites. We're now doing the same thing in Pakistanis and South Asians in Glasgow. We're recruiting about 20. When you lose weight, 10 kilograms in people with diabetes, this is, again, predominantly whites. We did a randomized trial published in The Lancet about 2 years ago, led by Roy Taylor and Professor Mike Lean. And these are my senior colleagues, both in their 60s, and they're fantastically energetic. So low-calorie diet followed by food reintroduction. The difference in weight between controls and intervention was about 10 kilograms at 1 year, and there was about a 40% difference in diabetes remission. So if you lose 10 kilograms as a white individual starting off with a weight of around about 90 to 100 kilograms, 40% will no longer have diabetes after 1 year, and it was about 36% after 2 years. We also showed it in a number of other papers, 2 in Cell Metabolism, 1 in Diabetes Care, and this one has just been published in Lancet Diabetes, that you can correct liver fat. That happens within about 2 to 3 weeks. The sugar level in those who undergo remission can often normalize within a week. Beta cell function normalizes. We showed that with clamps and beautiful data that Roy Taylor led out of Newcastle. And we also showed that the pancreas in diabetes is small and shrunken, and that it starts to recover when you lose weight. It starts to become less, irregular and healthy over time. Okay, so the summary of part 1. In white individuals, weight gain probably about 8 to 10 kilograms goes to pre-diabetes, another 10 kilograms to diabetes on average. Weight ectopic fat is critical to diabetes pathogenesis. Weight loss rapidly reverses diabetes. And it's because you improve liver fat, improve beta cell function, and you also improve blood pressure, lipids, cardiovascular risk. That's what happens. Okay, what about South Asians? Now, I did a review with Jason Gill. There's lots of reviews in the area, but I still think this is probably, even though I say so myself, but self-praise is no praise at all, I would say to you. But this is in the Lancet Diabetes, and it's been very well cited, I think. And I think Jason and I did a very careful agnostic review. We had no preconceptions, but there was lots of weak literature. But anyway, what the evidence showed, even in 2015, and it's still clear, South Asians, higher percentage fat mass, and I'll show you some data in the next slide, lower percentage lean mass, which is muscle. They have more insulin resistance. There was some suggestive evidence at that time of greater ectopic liver fat, but not convincing. There's suggestive evidence of beta cell failure earlier, but I'm not convinced that we've nailed that. Anyway, but these are the things in the black were clear. And there was suggestive evidence of less cardiorespiratory fitness, and I'll show you some data on that. So here is a paper we published in 2013, led by my colleague Nazim Gowri, who's did his MD with us. Almost 100 South Asians and 100 Europeans. Actually, and we had to take 13 South Asians away. And do you know why? 13 of them had undiagnosed diabetes. Middle-aged men, aged about 50, and 13 had diabetes and didn't know about it. And 2 of them had hemoglobin A1Cs well above 10%. And only 1 European had undiagnosed diabetes. Anyway, notice their waist to hip ratio was higher despite same BMI. The BMI was identical. So more central fat. They had less lean mass by about 10%. They had 10% more fat mass. And they had about 20% increased percentage body fat mass. And the reason that's 10 and that's 20, because there you're relating it to the total BMI. So, and they were shorter. So shorter, more fat centrally, smaller muscle mass, more fat. That's what it is. And it's exactly the same in South Asia, probably to an even greater extent. And it's probably even to a greater extent, I would suggest to you, maybe slightly different proportions in Bangladesh, where people in Bangladesh on average are even shorter. So what's the evidence for ectopic fat tissue? Well, I'm just giving you top line just because it's, this is a summary. It's not going to give you detailed data. Evidence that South Asians have more ectopic fat. Well, they have higher liver fat. This is the paper we're about to resubmit using UK Biobank data we've unpublished in 2 studies, along with other data. This is particularly consistent in women. There's a bit more heterogeneity in men. But if you add all 4 or 5 studies, highly convincing that South Asian women have higher liver fat compared to white women, match for BMI. If anything, the BMI was slightly lower in South Asians, which suggests that's an underestimate. They consistently higher waist-hip ratio, and we saw that in the Southall study. We saw that in multiple studies. South Asians, as you know, have higher triglyceride. And if you think about it, triglyceride levels in the blood is another measure of ectopic fat, because triglyceride levels are normally meant to be under 1 millimole, 1.3. But South Asians, they're higher. That suggests that they're already putting fat in the wrong places because they can't store it centrally. And they also have higher CRP levels. And CRP, about the 30% of the variance in CRP is due to fat tissue and fat tissue begetting macrophages. So that, and South Asians have higher CRP, which suggests that for the same BMI, they have more toxic adipose tissue linked to macrophages. So all these things tells me South Asians have fat in the wrong places sooner at the lower BMI. And then this fits with this data. This is a paper we published, I published with Martin Rutter and Alison Wright just this year. I think it's probably one of the best papers I've published, even though, it's observational. But let me just take you through it. On the left-hand side, what we looked at was the age of diagnosis of diabetes by ethnicity, and the mean difference in weight between people with and without diabetes. So let's go to a 42-year-old white individual who has diabetes is about 20 kilograms heavier. And that's about, I don't know what units you use in Pakistan, but that's about 40, you multiply by 2.2. So about 44 pounds heavier than a white individual who's age matched and sex matched without diabetes. If you look at a South Asian, a 42-year-old, he's about 7 kilograms heavier, much less. So that suggests, and that fits with the ectopic fat propensity, that for lower BMI, South Asians put fat in the wrong places sooner. They can't store it peripherally in your arms, or I don't know. We're not sure whether it's subcutaneous or visceral. The data are not clear. It might be deep subcutaneous, but whatever it is, the totality of ability to store it peripherally is less, and it goes centrally into the liver faster, possibly the pancreas, possibly muscle. And there are data emerging for that. And that's why there's a metabolic hit at lower BMI. That's why South Asians, and it's not the reason blacks get early diabetes, there's something different in blacks. I don't know what it is in blacks. I think in blacks it's probably more to do with beta cell dysfunction. I think it's beta cell dysfunction. And I'm going to skip the mortality point because it's a separate issue. Oh, sorry, there's Martin and there's Alison. For blood pressure, there is some evidence that if you develop diabetes at a younger age, any ethnicity, so the younger that you are, the greater the relative difference in blood pressure between someone with diabetes, whether you're white or South Asian, and someone without diabetes. Whereas if you develop diabetes at 80, if I develop diabetes at 80 or 75, I don't care. I'm not worried about it. I'm more worried about, 20, 30, 40, 50, because there the risk factors are more, the BMI is more, and the life years lost is more. Excuse me 1 second. I'm just going so, and that's what it is. And there's some evidence that the blood pressure is slightly less raised, but not by much in South Asians in, at younger age compared to whites. But, I think it's still very high actually, So if I put this in a cartoon, this is, the obesity in South Asians, more liver fat, less muscle. They're shorter, faster beta cell dysfunction compared to whites. Whites tend to be heavier, but they have more subcutaneous fat stores, less liver fat, and higher muscle mass. And that means when a white person develops diabetes, they have to put on more weight than the South Asian to develop diabetes. So South Asians are closer to the threshold because of their body composition. Physical fitness, what can we do about it? You asked me. Let me just talk about fitness. We looked at this, we published this in 2010. So this was this is a study that I had a hypothesis about, we did it. So 20 and 19 Europeans match for age. If anything, South Asians are slightly older, not significant. BMI is about 1 unit higher, but VO2 max, which is the ability to extract oxygen into your tissues, was less in South Asians, substantially less. That's almost 12. It's probably about 25% less fitness. And part of it's inherent. It's not because of, let me show you in the next slide. Higher fasting insulin levels, adjusted for BMI, higher 2-hour insulin, et cetera, this is a paper that we published in Diabetologia. And what we were able to show, I'm not going to go through it in detail, but by and large, South Asians were more insulin resistant. And when you corrected for the fitness, that insulin resistance went down. And the summary we had, again, this is not for detail. This is not the time for detail. The lower VO2 max explains 2/3 of the South Asian greater insulin resistance. And that VO2 max means that it might be to do with blood supply isn't as good because of smaller blood vessels. But the difference wasn't explained by low levels of physical activity, although South Asians were less physically active. But what it did explain was South Asians need to undertake higher amounts of physical activity for similar VO2s. This is probably too much detail. But what we are able to determine, and I'm going to skip that, is the implications for South Asians is that to get to the same level of cardiometabolic risk, whites have to, in whites, the criteria is that 150 minutes of moderate to vigorous physical activity for whites. For South Asians, because they have higher risks at the same levels of physical activity, they have to be more physically active to match that risk. And it's about 230 minutes per week. And that's to overcome their body composition and some inherent differences in tissues. And we put this in guidelines, JBS guidelines, which is the UK guidelines. We put that in. I was involved in that, actually kind of wrote this part. And my final couple of slides is the following, and we're trying to leave enough time for questions. So ethnicity-specific targets to minimize diabetes risk. So South Asians have to be lower BMI targets and be more physically active to try and minimize the diabetes risk. And they tend to have slightly higher waist-to-hip ratios, tend to be slightly shorter, and tend to carry more fat. So my summary is the following. Again, top line, there's a lot more molecular detail I can give you if you want, but I just think you needed the top line, and it's pretty clear. There's no dubiety about it. South Asians develop diabetes about 5 to 15 years younger in all parts of the world, and it's due to difference in body composition compared to whites. More ectopic fat sooner, lower muscle mass. They have a faster glycemia rise, and therefore they get a bigger microvascular hit at younger age. Affects kidneys and eye disease. They get earlier onset insulin resistance, possibly beta cell dysfunction, but we're not sure. And they tend to be shorter. The good news, though, is that in second generation South Asians in the UK, they tend to be taller. They have a slightly lower waist-hip ratio, so they're kind of getting a bit taller. Also, their waists are getting a bit narrower. And guess what? They have a 20% lower diabetes risk. This is a paper which we haven't yet published. It's been led by my colleagues in UCL. Has been revised, and we're waiting to hear from a very good journal. 20% lower risk of type 2 in second generations. And I suspect that risk has gone down even further in third generations as they're getting a bit taller, putting on a bit more muscle mass, losing a bit of the fat mass, and that then maybe corrects some of the metabolic defects. In the meantime, it's not rocket science, all of this. What you need to do as a community in Pakistan is to try and in your guidelines or facilitate people or encourage people in your clinics and your community and public health is walk a little more, 500 to 1,000 steps, which is 5 to 10 minutes extra a day, not 100, that should be 1,000, and eat a little bit less for some people. I think most South Asians tend to eat lots of good stuff, lots of vegetables, lots of, lean meat, as we know. Probably some people eat too much red meat, particularly the men, but And the other problem is more processed foods are coming into the community, you know, and that's a big problem, putting on weight. And, you know, that is going to be an issue. So we need to think about diet. And I've got, again, we can talk about that in questions. The good news is there's less cancers in South Asians, probably because they have a better diet and they smoke less. And as I said, the final thing is there are other ways to keep weight down, which are coming, such as GLP-1 receptor agonists. But, you know, they're expensive and they're medicines. I mean, how long can we give people a medicine for? And there is bariatric surgery, but not many people want bariatric surgery. So lifestyle, and how you convince people to improve lifestyle, you know, that activity will keep fat mass down, keep muscle mass up. And it's just an example. I'll give you a final anecdote, and this is my time. When I was about 25, my fasting insulin was one of the highest in 300 people. I was about 27. I was about 2 stone heavier. Both my parents have diabetes. But now my fasting insulin is 5. My HDL used to be 1.1, is now about 1.8. My triglycerides has come down. And it's because now I walk a lot more and I cycle more and I eat better. So, and slowly I made those changes. So my body composition has changed. And as it's changed, my risk factors have improved and my diabetes has been kept away. And then that's really what we need to achieve. And and then the other thing is, not only I, but some of our patients have done this, and they've done it in a way that their quality of life is better. They've got a lot more energy, and they're not going to get comorbidity and diabetes, and they're going to, you know, have more energetic lives and add more to the community. And I think that's where we need to get to. So I will stop there and be happy to take any questions if we have time. Thank you very much.
Thank you very much, Dr. Sattar, for a wonderful, wonderful talk. If nobody else has a question, I would like to start with a couple. So in one of your slides, you talked about the higher CRP. Is there a role for anti-inflammatories, you know, to decrease the risk? Not yet.
I mean, you know, there's the CANTOS study with canakinumab, but there's also the, you know, the colchicine trials, Colcott, but I don't think either of those two are going to make it in big time, because one's, you know, a subcutaneous injection and the other one is an oral tablet, but we haven't yet seen all the data, and there is a worry about non-cardiovascular mortality. So we're not there yet. I'm involved in another trial which is going to look at another agent, which I'm not at liberty to say yet, but if we do start this trial, maybe 5 to 10 years time, but we haven't yet fully proven. I think there is evidence that South Asians have higher IL-6 and higher CRP. In fact, I published some of that evidence. Dr. Faroohi from Cambridge published some of that evidence. You know, colleagues in America published some of that evidence. But to prove that actually dampening it gives you outcome benefit is another question. I can also guarantee you though, if people in the community able to become physically active and lose a bit of fat mass, their CRP will come down. And it's free, and their lipids will improve, and their blood pressure improves, and their diabetes risk goes down, and they don't have any side effects. So, yes, but you know, we are kind of, as people or as humans, lazy. We want a, you know, pill for every ill. So, I get that. Yeah, I get that. But yeah. My second question was about the type of physical activity. You know, like, is cardio more helpful than weight training, or there is no difference, or any would help? No, yeah. So you're right. Any would help. So we've developed a beautiful program in Glasgow, you know, with simple resistance exercise to keep muscle mass up, which can be done easily by anybody. A whole range of things. In fact, there's a paper coming out in JCEM that could, you know, we could easily adapt for your community. And what we need to get to is a menu of options that people can follow, both for diet, for activity. And the key thing is some of these things are really quite easy. You can do them sitting in your office, you know. Other things you can do lying down, other things you can do for 3 or 4 minutes a day. And other things is how we message things. Like, for example, you know, I've got my phone, and I'm now possessed with how many steps I take every day. You know, and if I come to the end of the day and I've only done 5,000 steps, I usually try and either just go for another walk for 10 minutes, Do you know what I mean? Just because then I know that actually that's what my average is. My average is about 7,000 or 8,000, you know, which is quite a lot. You know, the average South Asian, you know, parent probably walks 2,000 to 3,000 steps a day. But if you just even get them to say, look, can you just walk an extra 5 minutes, try and make it to 2,500? And once they get there and their muscle mass is built up, maybe they're encouraged to think, oh, that wasn't too difficult. Maybe I'll try to make another 500 steps to get to 3,000. And maybe I'll walk with my friend. Once the pandemic passes, you know, encouraging groups to go for walks, listening to your podcasts, you know, finding enjoyable ways to do it. Encouraging sport uptake for young people is really important in Pakistan. We haven't done that very well. I think we can still do it to keeping within our cultural norms. We can still do it, you know, and I think we need to think about these things. And also with food, not forgetting that I know we love our mitais, we love our samosas stuff. And I'm not saying we don't have them things, but we got to try and think about in moderation, you know, in moderation. I still have all of the things that you all have, but I have them less often. And I try and eat as much fiber and salad and, you know, and I still, but the good thing is I love my food as much as I used to, but it's better composition. Yeah.
I have a couple of questions and there's a few from the audience as well, if that's okay with you.
Yeah, of course. Yeah.
I'm intrigued by the ectopic fat, and I know that, you know, we need to exercise and all that, but, you know, is there anything that we can do to stop the ectopic fat? Because, you know, I think to me, it is kind of what insulin resistance means and what the slim PCOS mean. Because, you know, we've, like say in the pregnancy diabetes clinic, you would have patients who were as thin as a rake and they would still have diabetes. So, you know, I think they've been trying to maintain a healthy diet, but still haven't been able to prevent ectopic fat. And for some, no matter what they do, it doesn't go away. That's one question. And, you know, I think, do you relate it to, obviously, the cardiovascular, the perfect storm that is brewing? Because so many young people over in Pakistan in their 30s, 40s are having MIs now. And
really?
Is that because, yes, there's a, I mean, Kiran will probably substantiate that, but I know many people in their early 30s who have stents in situ. So this is, as I said, it's a perfect storm. And I think it's unfortunate that people can't go out for walks for safety's sake, because whenever I go to Pakistan and I ask my sister, shall we walk to the shops? And she says, no, I don't want my purse snatched. I don't want to walk and I don't want to go. Nobody walks here. It's unfortunate, really. And I think we all need to think about ways to do this, as you say, going in groups. And my last question was, and I think one of the audiences asked as well, you know, the Fermanki paper, the lower risk of the second generation, is it obviously because they are perhaps more westernized in their attitudes towards diet and exercise, or is it just environmental?
No, you know what I think it is. It's a brilliant question. So I think what's happening is, I think it's probably intrauterine nutrition or something, and less infections. You know, and what happens therefore, or a bit, you know, is that. And I think it might be changing in Pakistan. I don't know. As the second and third, and in the new agenda, not, you know, second and third, are younger people getting taller in Pakistan?
Some of them are, yeah.
Yeah. So, and I think that some of them, those who are probably getting better nutrition. And I think what's happening is, and you know, there's a paper just came out, the NCD global paper in the Lancet 2 days ago, 20 centimeter difference between Netherlands and some of the poorest countries, and it's to do with early nutrition and intrauterine nutrition. And so some of my nephews now are 6'3", you know, and they're, you know, and how did that happen? And 4 or 5 of them are all about 6 foot. It's because we're not getting infections, and we've got availability of lots of good nutrition, and they're eating well, and their femur lengths grow longer, and then they put on more muscle, and they seem slimmer as well. And that's exactly what we saw in the UK Biobank data. Okay. So I think that's what's happening. And I, you know, and when you say some of in Pakistan, I suspect what's happening is that the good nutrition is going to some, probably more in affluent areas, you know, and that's probably, you know, that's what you're seeing. And in terms of your first question, the lean, I'm not saying it's the whole thing. I think where you have people who've got diabetes, say someone who's got GDM and their BMI was, you know, 21. My goodness, that tells you that there's something else. You know, I probably painted a simplistic picture, but maybe there for that individual, it's more about look get your muscle mass up, you know, to counter. It's almost like it's an interplay between your muscle is your engine where you burn your sugar, and your fat is, you know, where you're overspill. So if you've got low muscle mass, but low, you know, and low BMI, maybe you're more likely to overwhelm that to get insulin resistance. So what you need to do is either build up muscle or cut the fuel, or a combination of both. And if you've got an average, you know, if I kind of knew this from my family, both my uncles developed diabetes with BMIs of about 24. And I thought, oh my goodness, you know, and I got, and that was when I was about 30. And then my mum developed it, you know, women develop it a bit later. Same in Pakistan. I suddenly thought, my God, I'm really, you know, gun is loaded. So I had to then build up my muscle mass, and I lost a bit of fat mass. So I've changed my ratio, and my sugars at hope, you know, inshallah, you know, I'm not going to get it for, you know, at the moment.
No, you won't.
So that's what it is.
Yeah.
So personalized medicine, I think, you know, and what I think in Pakistan would be good is to develop a degree of an option saying, look, here is how you can reduce your risk. One could be activity, and here's some simple tips. Both an activity could be walking more, or it could be getting yourself a bike in home. It could be skipping, or it could be resistance exercise. And here are some tips: get a bottle of water, and, you know, or another one could be number of types of diets. Cut your sugary drinks and replace with diet drinks. Try and eat more salad with your main meal. Cut your portion size. You know, instead of having 3 chapatis a night, maybe, you know, cut to 2.5. You know, maybe having less rice, or don't have the extra pizza every night. I mean, you know, or cut your lassi, or, you know, there's a range of things that I can give you. You know, we can make that up. Choose one of these things. Choose what you think is best, and then if it doesn't work, and the other thing is, for some of these things, you have to retrain how you enjoy your food. You know.
Yes.
Yeah.
How to eat it and all that. Yeah. There's a couple of other questions from the audience. Are we okay for time, Kiran?
I think we should move on with the second one, but there will be another session at the end.
Okay.
I think a lot of questions are coming.
Okay.
Do you want me to come back? I'm going to listen. Just keep on. Okay, I'll stay on. I think, let's move on for fairness to, I think, to Heather. Yeah.
Fine. Yeah. Okay.
Okay. So it's my pleasure to introduce Dr. Heather Wadams. She's a close friend, and actually from my tribe of pediatric endocrinologists. So Dr. Wadams was born and raised Canadian. She, I guess if you're born, you're Canadian. So she finished her pediatric residency at Geisinger Medical Center in Pennsylvania, and her pediatric endocrinology fellowship at the world famous Mayo Clinics. She is triple boarded in pediatrics, pediatric endocrinology, and obesity medicine. Currently, she is in Abu Dhabi, where she's the consultant pediatric endocrinologist at Sheikh Aboud Medical City, which is a joint venture with Mayo Clinics. And her main interest is in obesity, new treatments of obesity, thyroid, and bone metabolism. And off to you, Heather.
Oh, thank you for such a kind introduction. It's nice to have a friend. Hang on, I'm just gonna get ready to share. I'm learning how to do this. As I was kindly told that Canadians and North Americans should be more tech savvy than what I am. So there's my weakness right there. So I'm going to talk about hypothalamic obesity, what's new in treatment. I have nothing to disclose. I will be discussing or mentioning off-label use of medications. So I'm not asking you to give them, I'm just asking you to follow your local government recommendations. My objectives are defining hypothalamic obesity, the etiology, regulation of energy, pathophysiology of hypothalamic obesity, treatment, and then what's new coming down. So hypothalamic obesity, just to start as a definition, it's a complex neuroendocrine disorder caused by hypothalamic damage or dysfunction resulting in severe dysregulation for energy homeostasis. It's a clinical picture characterized by weight gain, extreme obesity and hyperphagia, resting energy expenditure, and reduction in physical activity. How do I get rid of this? Oh, perfect, thank you, never mind. It can also have significant hyperleptinemia due to anatomic leptin resistance, inadequate hyperinsulinemia for their degree of obesity, impaired incretin response, reduced levels of blood catecholamines and urinary metabolites, and as well as reduced alpha melanocyte stimulating hormone. And it has a severe negative impact on quality of life for many people. So the etiology, there can be congenital and acquired. Acquired are typically your cellular tumors, supracellular tumors, neurosurgical procedures, cranial irradiation, head trauma, inflammatory disease. And your congenital are typical syndromes like ROHAD, your rapid onset obesity, hypothalamic dysregulation, hypoventilation, autonomic dysfunction, Prader-Willi syndrome, Bardet-Biedl syndrome. You have genetic mutations such as leptin deficiency, leptin receptor deficiency, your propio-melanocortin deficiency, and your PCSK1 deficiency, et cetera. The regulation of energy is a lot of work is done in the hypothalamus. It contains key centers for the integration of afferent and efferent signals, regulating body weight. You have your paraventricular nucleus in your anterior hypothalamus, your arcuate nucleus, your ventromedial nucleus in the middle hypothalamus, and your dorsomedial nucleus, as well as your dorsal-hypothalamic area in the posterior hypothalamus. There's a role in the hypothalamus in sympathetic activity. The activation of the melanocortin receptors in the ventromedial hypothalamus also increases sympathetic outflow to the skeletal muscles. And in the for parasympathetic activity, any damage to the hypothalamus may result in disinhibition of parasympathetic signaling, resulting in hyperinsulinemia. So feeding behavior is also influenced by the hypothalamus. Meal initiation is fully regulated, and meal termination is really a response to the gut-derived hormones such as cholecystokinin, peptide YY, and glucagon-like peptide 1. So food choice is influenced by learned associations and food cues. So when you have your physiology of eating and weight regulation, and you look at all of your peptides, you have your ghrelin, which is the one orexigenic signal, and it comes from the fundus of the stomach and small intestines. It increases when fasting, it decreases with the stomach stretch. You have in your small intestines your cholecystokinin from the L cells in the small intestine, secreted in response to fat and protein. It stimulates gallbladder contraction, slows gastric emptying, reduces appetite. Your GLP-1 delays gastric emptying and increases satiety. It reduces hepatic gluconeogenesis and reduces appetite. Your peptide YY is a potent appetite suppressant. Your insulin is secreted in response to eating. Insulin is one of two long-term adiposity signaling hormones. The other one is actually leptin. And centrally, it deactivates the feeding response in the arcuate nucleus. And in obesity, insulin resistance attenuates this response. So leptin reduces food intake. It increases energy levels. It turns off your weight gaining pathway and turns on the weight loss pathway. But patients with obesity tend to be leptin resistant. And we don't completely understand why, but we theorize it's actually downregulation of receptors in the brain. So for your this is a cross-section of your hypothalamus. When you look at your arcuate nucleus down here and your paraventricular nucleus above, your leptin and your leptin and your insulin activate the POMC, which is your anorexigenic pathway, and it talks up into the paraventricular nucleus to turn off your appetite. You have your agouti-related protein and your neuropeptide Y down here. This is the only pathway that is activated by ghrelin, but it's also turned off by all of the other peptides. So the signals of GLP-1, leptin, insulin, PYY, CCK will turn off the agouti-related peptide and neuropeptide Y. So where we go from here is most of the studies that I'm going to talk about are really done on post-surgical patients who've had craniopharyngioma. A lot of the studies have very small numbers. So there's not a huge N for a lot of power, but I'll go through the overall picture of it. So just for a demonstration of hypothalamic obesity and how it affects some and not others, we have person A on the right, but a small tumor confined just to the sellar region as pictured in image D. And person B on the right had a hypothalamic suprasellar tumor pictured in C. And person B clearly had the hypothalamic obesity where the person A was spared. Oops, sorry, I had another slide there. So the consequences of hypothalamic damage, it is predominantly a clinical diagnosis that can have actually a constellation of 6 domains. So there's psychosocial disorders, there's which is impulse control, depression, anxiety, severe food cravings. They often require additional psychosocial and psychiatric support. You have hyperphagia, which is your lack of satiety or short duration of satiety. They have preoccupation with food, food-seeking behaviors, night eating. These are all signs of hyperphagia. Sleep disturbance can be primary hypothalamic dysfunction, such as hypersomnia, narcolepsy, disturbed sleep-wake cycles, or it can be secondary to obesity itself with obstructive sleep apnea. Decreased energy expenditure is your resting energy rate tends to be, or resting energy level is much lower in hypothalamic obesity. For hyperinsulinemia, insulin resistance, it may be due to increased vagal tone as well as obesity itself. And for hypopit or hypopituitarism, we want to have timely treatment for any of the deficiencies from the pituitary to prevent impaired metabolic activity such as growth hormone deficiency. Growth hormone deficiency can be masked by leptin and insulin because both of these peptides actually induce linear growth in children, so they can have actually growth with without growth hormone. So the treatment timeline actually really begins probably closer to 1996. Fen-phen, it was introduced about that time, and fenfluramine was actually pulled off the market in 1997 due to valvular disease. But that was one of the very first weight loss drugs and appetite suppressants. And during that time, there was 1998, there was SSRIs and sibutramine coming out, being studied. In 1999, studies began with octreotide. 2001 was Mazindal. And then we bring in dextroamphetamine, supraphysiologic T3. Then we move into growth hormone. Sibutramine made a comeback in 2007 with more studies. And that's when we started looking at bariatric surgery as an option for treatment, as well as vagotomy. Then we started with revisiting methylphenidates and more stimulant medications. And then in 2011, we had metformin diazoxide combination. In 2012, we had the GLP-1s introduced. 2013 is missing, and that's when the deep brain stimulation electrode to the nucleus accumbens had started being studied. And then 2015, we had the fenofibrate metformin. 2016 brought on beloranib. And then just recently in 2019, there's a new medication out called setmelanotide, and we'll talk about that later. So the very initial intervention you try, of course, is lifestyle interventions. And the literature I have read is really, it's mostly non-responsive to conventional lifestyle modification of diet and exercise. The diet interventions can achieve results if strictly followed. But as you can see by the table, there's only one patient who had a significant reduction in BMI, and that was the one patient in the pediatric hospital in the first line. So the other ones either had a slower weight gain or absolutely ineffective in lifestyle modification. So then when we move on, one of the first things, of course, we do is we replace the deficient hormones, and replacement of growth hormone is considered safe regarding craniopharyngioma recurrence risk, but the long-term benefits of body composition was controversial. And actually there was no weight loss in the studies that I reviewed. So T3, in the initial study in T3, there was improved thermogenesis, there was improved daytime lethargy and weight reduction. And then in 2015, it was reviewed again by Fernandez et al. and they found, or by Vincent-Nayol, and they found absolutely no beneficial effects. There was no change in brown adipose tissue activity or energy expenditure. And I think the T3 supplementation just stopped right there. Moving to central stimulating agents, the dextroamphetamine, it may reduce hyperphagia by inhibiting reuptake of dopamine, norepi, and serotonin, causing anorexia. This stabilized the body mass index, diminished continuous weight gain, it increased spontaneous physical activity, and improved daytime sleepiness. But it's actually not approved for weight loss by the FDA at this time. Sibutramine, the serotonin and noradrenaline uptake inhibitor, it reduces appetite, prevents reduced energy expenditures. It was being studied up until about 2010 when it was pulled from the market due to cardiovascular events. I believe there were MIs involved. So it's now been removed from the market, not available. So mazindol and ephedrine suppress food intake by direct stimulation of the beta-adrenergic receptors and inhibit the feeding center of the lateral hypothalamus. So it decreases hyperphagia. It's not currently FDA or EMA approved. Methylphenidate may elicit a food reward response and suppress the drive to eat. And it's currently not approved by FDA or EMA for weight loss. Phentermine is an appetite suppressant. It's actually been around since 1959. It has a really, really good safe track record, but it's a highly controlled drug, and it's only approved for adults for weight loss in the USA. Phentermine and topiramate, also known as Qsymia, is an appetite suppressant with topiramate, and the topiramate mechanism of action is not well established. It's also approved for adults for weight loss. And lisdexamphetamine, Vyvanse, has been approved for binge eating disorders in adults, and it's an ADHD medication in children, but it's only been approved for adults in weight loss. So these last three medications, none of them have been approved for children or adolescents with obesity or hypothalamic obesity. So moving to our anti-diabetic agents, you have metformin and diazoxide, and this improved insulin sensitivity by decreasing hepatic gluconeogenesis, and the diazoxide reduced insulin secretion. Unfortunately, they would develop peripheral edema, and then these increased insulin levels actually contributed to the development of diabetes mellitus in some patients, so it's not recommended by the FDA or the EMA for treatment of obesity. GLP-1, they have a sustained weight loss and improvement in cardiovascular and metabolic risk factors, and they are FDA approved for, actually liraglutide is FDA approved for children 12 and up and adults. And there are other newer GLP-1s that are going to be coming down the pipeline for adolescents. Somatostatins, we have octreotide, which reduce insulin secretion. You have moderate weight loss in the initial study, and then in the second study, there was no weight loss. But unfortunately, the adverse effects of gallstone formation, abdominal discomfort, mild glucose intolerance, peripheral edema, and diabetic hyperosmolar non-ketotic coma makes it not recommended by both FDA and EMA. So beloranib is a methionine and aminopectase 2 inhibitor, and the mechanism of action is not fully understood, but it was found to induce weight loss, decrease leptin, increase adiponectin, which decreased lipogenesis and increased fat oxidation and lipolysis, and actually was showing good promise. And in the phase 3 trials, it was stopped due to 2 fatal PEs and some DVTs in some of the study participants. So it has stopped. Fenofibrate and metformin it's a PPAR agonist, and it's improved insulin resistance and lipid profiles, but no improvement in body mass index in those patients, in those studies. So lorcaserin, which is marketed as Belviq, reduces appetite by activating a type of serotonin receptor known as the 5-HT2C receptor in the hypothalamus. And it was just recently removed to the market due to an increased cancer risk, which outweighed the benefit. So it's no longer available. Naltrexone bupropion, called Contrave, exact mechanism leading to weight loss is not fully understood. The combination is theorized to work synergistically in the hypothalamus to promote satiety, reduced food intake, and enhanced energy expenditure. And it is approved by the FDA for people with obesity, but there are no studies yet on hypothalamic obesity. So moving on to oxytocin, they are limited to specific anterior hypothalamus damage. So it showed improvement with regard to emotion identification and adverse eating behaviors, but long-term effects are not known and studies are ongoing right now. So for truncal vagotomy, it stops the parasympathetic stimulation of the beta cells in the pancreas, reducing, hyperinsulinism. And then the deep brain stimulation in the nucleus accumbens is actually considered experimental right now, but there was just a publication a year ago talking about 2 refractory obesity patients who actually were able to increase their resting metabolic rate through deep brain stimulation. So it's showing promise in these refractory patients. And in bariatric surgery is usually the last resort. They initially studied the laparoscopic adjustable gastric band, improved binge eating, but it did not really result in weight loss long term. So surgeons have moved on to the Roux-en-Y sleeve gastrectomy and biliopancreatic diversion. Weight loss occurred after each of these, but much less than patients with obesity in the general population. And the long-term benefits and risk for adverse effects really vary, and it really should be considered on an individual basis. So in Van Ayersaal's endocrine reviews, they have a really nice algorithm for treatment of hypothalamic obesity. They talk about the 6 domains, where to go with the 6 domains. And I found it, really actually informative when I was reviewing. And we focus mainly, for our talk, we're focusing mainly on the hyperphagia component. Although lifestyle changes are shown not to be as effective, but if we can combine it with other modalities such as psychosocial support, psychiatric support, adding our medications as we need, our stimulants, our GLP-1s, looking to see if we have a good response. If we have a good response, we continue these medications. If it's insufficient, try switching to another medication, or then considering bariatric surgeon with a good discussion with the families. So for future directions, recently looked at clinicaltrials.gov. There's a study ongoing that looking at tesofensine and metoprolol in patients with hypothalamic injury. And this is another SNRI with a beta blocker. So I'm waiting for that data to come out. And the second study I'm really anxious to finish is setmelanotide as a phase 3 treatment trial. And I actually spoke with one of the physicians who's the lead in Marshfield Clinic, who looks after Bardet-Biedl patients, and most of his patients are enrolled. And this medication shows great promise as an NC4R agonist, which will really help turn off the hunger for these patients who just cannot control appetite with hypothalamic dysfunction. So this study should be published in about May 2021, I was told, are the results. So overall, the evidence for hypothalamic obesity interventions are very modest. I feel like I gave lots of bad news, but there are individual variations. So it is worth trying these approved medications to see what works for your patient, which goes hand in hand with an individualized treatment plan. And we really need continued research for novel therapies, or even, what do they call it, where we reuse and remodel our old therapies. So that is the end of my talk. I don't know how to not share. Kiran?
Yes. Thank you for a very comprehensive overview. I think we do have a question. I think the first one was, any role of topiramate on weight loss in any trial?
So there are a lot of adolescent studies and adult studies with topiramate alone, and they have shown good results with weight loss, but it is not FDA approved as a weight loss medication at this time, unless it's combined with Contrave. So it's off label.
I think we are going to invite our panelists as well to take part in the discussion.
Did you want to ask Dr. Naveed Sattar to unmute and offer them the questions that were there from before?
Mhm.
Okay.
Yeah, no, I was listening to Heather's talk with yeah, it's a complex area, Heather. I mean, in general obesity, we're obviously very excited about semaglutide and some of the new combination therapies, you know, GLP-1, GIP, perhaps with, you know, PYY. Do you see much of a role for the combination therapies going forward in hypothalamic? Or does it?
I think it's really worth studying, to be honest. They really show promise. I'm excited about the setmelanotide because it actually works at the receptor in the brain, which is where we really need these novel therapies to be targeted.
Okay.
I think I have a question for Dr. Sattar. I think the question was about gene editing. I think that a couple of people asked. Let me pull that question.
In a word, it's not my area of expertise. I don't know. I don't know if Heather can answer that, but I mean, I wouldn't recommend it. Would you want your genes edited for this? you know, the reality is, in terms of lifestyle, you know, there's two complex areas, but certainly for lifestyle, we are now in a far better position in terms of what we know that works. And we can offer people a range of different options. And I think as a community in Pakistan, what you should do is work with your public health people. And we need to do the same in the UK, we're starting to do it, is to develop a menu of different options and then put it out to people in a way that's supportive, non-judgmental, and perhaps also, you know, allow people that they have these options supplemented by maybe some apps or videos, but also, you know, if people maybe fund a post where somebody could phone up someone if they can't work out what's going on. We can definitely help far better with lifestyle now. And I think I think making it obvious for people what they do and what they change and how they change will help support lifestyle change. In the past, we've made it too complex. All we've said is you go and lose weight, and then they leave the clinic and they say, well, you know, and they'll go out the clinic and they might say something, you know, I'm not going to say a swear word, but you can imagine, well, I've been trying that for the last 20 years. How, you know, it's not, but they don't know how to, but you need to give them some very directive advice, which is pragmatic, simple, and also supportive, and also encourage failure, if that makes sense. Yeah. But I wouldn't go near gene editing for this, not personally.
I mean, I think if you exercise continuously, if I remember it rightly, I was once at a talk and there was this speaker who was saying that if you walk 30 minutes a day for 6 months, you alter 2,000 genes. So, you know, you can do your own gene editing as such, like when, as you say, lifestyle measures are there. So like 2,500 genes are literally edited if you exercise for, like, even if you're an Asian, so maybe you need 45 minutes a day. So if you're doing 45 minutes a day for 6 months, you've changed 2,500 genes. Like, so that's I think good enough for me.
Yeah, no, you're probably right. Probably through well, I don't know what the process is. Is it post-translational gene editing? I don't know what it is, or what the mechanisms or pathways are. Or, but you're completely correct. I know for a fact that on circulation, we've looked at a few papers where protein signatures have massively changed with physical activity and diet, you know, substantially. So you are completely correct. And the proof of the pudding is in the eating. And so, you know, as I say, when you look at people who have made big lifestyle changes, we had a patient, we had a radio call recently, Radio Awaz in Glasgow, and an individual from Edinburgh came on. So, but we allowed him on. It was okay. But he was a Pakistani shopkeeper, and he a few years ago, something happened in his life. I won't go through it, but effectively he started to walk a lot more, improved his diet, stopped drinking iron brew. And over a period of time, he lost 2 stone in weight, and he no longer has diabetes, you know. He made some gradual changes, and he got to a point in his lifestyle where he was feeling tired, fatigued, didn't have any energy, developing other conditions, and he was young enough to make changes, and he's now at a point where he's got so much energy, doesn't have any diabetes, not on any drugs, and he feels like a new person. So it is achievable, you know. These things are achievable if people are motivated and if we can get the messages across in a supportive way. I'm not saying everyone will achieve it, because if it was easy, people would do it all the time. But you know, I think our messaging needs to improve. That can be a lot better. Yeah.
I have another. Go ahead.
Carbohydrates in our diet. So if we eat less carbs, do you think that'll help us in our body composition?
Oh, I don't know. Maybe Heather. My personal view, we don't have enough evidence that it's carbs versus fat. What causes obesity is both, you know, refined carbs and also fat. And actually, in the UK, most people are still overweight by eating too much fat rather than carbs. In Pakistan, you know, based on the Pure study from Salim Yusuf and colleagues, it looked like there was a lot of carb-rich diets, and but I don't think there's definitive evidence. We're hoping to do trials in this space where we compare low carb versus low fat, or for diabetes remission. Will we find any difference? I suspect it'll be total calorie content that really matters, and what's sustainable is really what I think. Yeah, I think there's a question there for Heather. I don't know if that's, you know, what should be the target reduction in weight with liraglutide?
Yeah, what's the optimal duration of therapy with liraglutide for managing patients with obesity, and what's the target reduction in weight with liraglutide?
So if you give a medication a chance, which they talk about 3 months. So the way liraglutide is given, you start like at 0.6 milligrams for 1 week, and then you go to 1.2 for a week and 1.8. And that's all to reduce the gastric upset. Once you're at the full dose of 3 milligrams, you really stay there for 3 months. And if you achieve 5% weight loss, you continue. If you don't achieve 5% weight loss, then it's time to reconsider the medication and try something new. And indefinitely, from what I understand, is you can be on liraglutide. And I know that doesn't sit well with Dr. Sattar's talk.
No, it's not that it doesn't sit well, Heather. I think it does. I mean, I'm involved in a lot of the drug trials as well. You know, I'm involved in cardiovascular guidelines, so I know all about cardiovascular disease, diabetes. So I've got a good context of where the world is, and you know, there are some really exciting things going on in drug trials, as you say, and I'm involved in some of them. Actually, I'm involved in the kind of Lilly product outcome trial. I'm on the executive committee for that, so which makes you lose 10 kilograms. So these are really exciting times. But these drugs are expensive, and they can't afford them to use them for long-term obesity for everybody. We're going to have to, even if the trials are positive, there will be select use because of their cost. But you know, I see somebody asked about sleep hygiene and sleep. Yes. And I think that's another area that's coming forward. You know, I think, you know, probably Heather sees problems there in your clinics, but you know, definitely. Yeah. So Heather, I don't know if you want to say.
I live in a very nocturnal society here in Abu Dhabi. Nobody wants to sleep at night. Everybody goes to sleep at Fajr prayer, wakes up at 8 o'clock for their online school. So they get the 3 hours sleep. But we know for adults, and all the studies are mainly on adult, that if you have 5 hours of sleep or less a night, your insulin resistance goes up, your leptin goes down, you're craving food, and the food that you're craving are the high calorie dense carbs. So you really need to have people sleep at night, and they should be sleeping for, you know, adults, it should be 6 to 8 hours. And then for children, we aim for 8 to 10. But I mean, those people who work and are employed overnight, and physicians who are on call overnight and stay awake, they actually need 400 calories less in a 24-hour period just to maintain their current weight. So you can imagine if you're making effort to lose weight, you actually need to have even more of a negative energy intake beyond 400 calories if you're staying awake at night. It really just makes sense to sleep. So.
I mean, it's a difficult thing in terms of, you know, the culture, obviously, but I think you're right. I think the clear evidence is that people who don't sleep enough just eat more, and partly of it's centrally brain signaled of appetite, and partly it might be time that they're awake for longer, and they get bored and they eat, they munch, but I think it is definitely affecting your appetite. You're completely correct, and genetics show that now as well, beautifully. So good sleep is really vitally important. But what we don't have is randomized trials of improving sleep, but they're coming to prove that actually, if you can get people to improve their sleep, that facilitates weight loss. I think
it makes weight loss easier if you're trying.
It does, yeah. And actually, we all know that, when I've been tired a few nights, I will definitely eat more the next day because I'm a bit grumpy and tired, fatigued, and I'm trying, we just do that. Whereas if you good sleep, you do eat better. Yeah. Completely correct.
What about sleep apnea? And do you guys see it's more prevalent in South Asians? Does that contribute to more high blood pressure or inflammation, or no, not really?
I don't know. Heather, do you know that data?
I don't know in relation to South Asians, but we know people who suffer obstructive sleep apnea and they're not using a CPAP machine. It's the same sleep deprivation. They're not getting any quality sleep. So their ghrelin goes up, their leptin goes down, and they start craving, and their insulin resistance goes up. So we really need to fix the OSA before we can actually facilitate weight loss. It's the same thing as about number of hours of sleep. It's quality in there as well.
Yeah, I would agree. I mean, I don't know the sleep apnea data by ethnicity at all. I mean, I know it for lots of conditions, but not for that, I'm afraid. Sorry.
I'm going to ask our panelists to just comment a little bit about, the issues that we face in Pakistan regarding, the management of obesity in terms of.
Dr. Amina Umer here, may I?
Sure,
Yes.
sure.
Yeah, go ahead. Yeah.
Thanks to Dr. Naveed Sattar and Dr. Wadams for such a valuable and informative talk. One point I would like to add regarding the first session on South Asian obesity is the decreased bioavailability of vitamin D in obese patients because of its deposition in the body fat compartments. So the South Asian population, especially the children, elderly, and the females, who already have lower levels of vitamin D because of lack of proper diet, social and religious customs, and remaining confined to the indoors, obesity really adds to the problem. So I think losing weight is important in improving the bioavailability of vitamin D as well, apart from improving the insulin sensitivity.
Yeah,
Again,
you are completely correct, but what you've got to be careful for is cause and effect. So you're completely correct. So there was a beautiful study led by a lady called Elena Hipponen, published in PLOS Medicine, which showed using genetics that people who are obese tend to have lower vitamin D levels because it's because it's sequestered in fat tissue, and that with weight loss, vitamin D can go back up. But that doesn't mean to say that's the mechanism for benefit. It's the weight loss, the benefit through reducing ectopic fat. And there are now a number of randomized trials. There was one published last year, certainly in white populations, that vitamin D supplementation and its D3 in high doses does not change glycemic levels or reduce diabetes. And it doesn't, and there was the VITAL study led out by Boston and showed no benefit of vitamin D supplementation on cardiovascular disease or cancer. So I think vitamin D might be a red herring for cardiometabolic disease. I think it's more a marker for bone disease, and and clearly it is for but for cardiometabolic, I do think it's the cause. I think it's just an epiphenomenon, is my gut feeling. I don't know, Heather, you know any of that sort of area, but
actually I've kind of read the same studies you have. So vitamin D went from the panacea to everything to now we're not so sure there's much value. Maybe there's value in COVID. I don't know.
Well, I'm not convinced there either. We wrote one of the very first papers, it's low when you get sick. It's an acute phase reactant. It goes down. Having said that, somebody's doing a randomized trial. So if there's a 5,000 patient randomized trial started in Queen's University in London. So that's the only way to get at the truth of vitamin D, is to do proper randomized trials. And I'm sure there must be randomized trials of vitamin D supplementation in South Asians. There must be, and diabetes, and I bet you they're negative. And if you haven't seen them out published, it's because people can't get them published because there's publication bias. Yeah. So.
Okay, may I add to something?
Yes, Urooj, if you have any questions.
First of all, I want to say a very elaborative talk by Dr. Sattar, and he's very right. We South Asians, we have sorry, we South Asians, we tend to have more waist circumference. So our heights are small, and we have that's why our BMIs are considered, the cutoff for our BMI is 23 rather than 25. But beside the lifestyle, the genetics are playing a role. I think gut microbiota is also there, which is playing a role in this. So what do you think about that, about gut microbiota? What's your take on it?
I'm not convinced at all. I think it's a pile of rubbish. Actually, I'm not. I'm stopping saying what I really think. You know, there are a number of small trials, but there's only a handful, and most of them are on animals, and they're not. You know, there is some evidence that gut microbiome does work in certain conditions. Is it what condition? Is one condition, or you can give them. Is it celiac or not celiac? I don't know. But in terms of cardiometabolic disease, I'm not convinced, because my sense is it's a measure of your lifestyle and your diet. So having said that, I think one has to remain agnostic until we get proper randomized trials.
Yeah. Okay. Fine.
I'm a very strong trial advocate, because a lot of things could be associative, but that doesn't mean to say it's cause and effect.
You're right. So lifestyle, as you're saying, is a cornerstone. But in Pakistan, what we see is, as we go toward, I'm in Sindh, so as we go toward Punjab, Dr. Maleeha and Dr. Amina will agree with me that when a person is a little obese, they don't call them obese, they call them healthy. That's the mindset. And then the mindset over here is, when you get married, you have to gain weight. If you don't gain weight, people think that you're not happy with your marriage. So these concepts need to be debunked, actually. And lifestyle is the cornerstone, and we have to work on that, and we keep on talking about that. Yeah. But some things are integrated in our minds.
No, I completely get it, and it's a lot. Lots of cultural challenges. My family, my mother's family are from Faisalabad, and my father's from near Multan, from villages. So I saw all of that when I was over there, and there are lots of issues, and you have to tread very carefully. But the good thing is there are lots of very bright South Asian women like yourselves who can, gently start to move the agenda forward in a way that's, you understand the mindset. So I think between you guys, you could probably work out how best to tackle some of these issues, but it's not going to be easy, but there are ways to make sort of positive changes, and but I'll leave that to you to do that. But I get it. It's not easy. Yeah.
It's not easy, but it has to be done, of course, and we have to talk about it.
Yeah, exactly. And
I think there is a lot of role for the steps. I think we underestimate counting steps, and that's easy. Once you start counting them, then you realize that, my goal is, for example, 5,000 steps. So I'm already at 1,000 by just, running after the kids and doing the kitchen stuff. So I just need to do a little bit more, and you don't have to leave the house. I guess it just needs a little bit more motivation than what we all have, certainly what I have. But I think that's a cheap, no cost exercise, and really, really understated and underappreciated.
Yeah, and I think you're right. But it's not easy, but there are simple ways that we can do this. But what, I really would encourage the societies there, if you can, to maybe, for diet, we've made it far too complex, and for physical activity, we've made it, exercise 3 times a week, 5 times a week. It's too hard for many people. So people tend not to do it. But if you could make it into small bite sizes and give them the vision of, whoa, I didn't realize that, if I just walk up the steps 10 times, that might be, get my heart racing. That's a twice, once a day or twice a day, that's something extra that'll build a little bit of muscle mass that might make me reduce my chance of getting diabetes by a year. I don't know, simple things, small
Telling
bite
them
size.
to go through, take the stairs rather than the lifts when they are in the malls or for their apartments. Yeah, things like that
I think though there's huge
can
reliance
help, of course.
on cheap labor that comes into your homes and does jobs for you as well. Like say my trip to the supermarket and coming back with 4 or 5 bags is like about 4,000 to 5,000 steps. Like one trip to the supermarket is like that. And I think that, we have to encourage that culture. So not only is this healthy concept there, a bit of overweight is healthy, but having a few people to help you at home is also a sign of affluence. So we really have to debunk that as well. I think that is the first thing that we need to debunk, because it is okay to do your own work. Really, it is okay to do your own jobs around the house. It is, but I think it's one of those things that people just rely so heavily on.
Yeah. The best you can do is give people the best evidence base in a way that is digestible and understandable and non-judgmental, but then it's up to them. And it's up to them to motivate themselves. And you got to keep chipping away. It's not one message once. It's got to be many, many times. And if you can get some, I would guess, if you can get some of the major stars on your backing, that then potentially helps, to make your case. And because we know that our community relies a lot on listening to the major movie stars or whatever, or sports stars. That's the way to do it, I think. That to change the agenda, and it's going to be a gradual. You're not going to go from overnight to full success. It's small little bits, chip away with the advertising, public health messaging, maybe
the thing of going from one place to another on foot by foot, which is very easily England, or because of the weather. In Karachi, the weather is too hot. You cannot walk and go to the supermarket and bring the thing. And we like to go in the car or take a taxi or something, because the weather also, the climate also, go at 12 a.m. I'm going and getting the grocery at that hour.
Right. You did right. And
that thing also has an effect.
You're right. And I think in Abu Dhabi, for example, Heather, I'm sure you see that in summer months, they're so hot, people just don't physically active.
Yeah.
But I also find they make very little effort to be able to go to a place where they can. So, yeah.
We go to malls. We go to the malls.
Yeah.
I mean,
I would like to give a comment, may I?
Yes, go ahead. Yeah, go ahead. Yeah.
Right. Excellent talk by Dr. Sattar regarding South Asian obesity. Now, I totally as we all know, the massive proportions in which diabetes is rising in Pakistan, and especially the fact that it's occurring at lower BMIs and at a younger age, because we conducted a local study at LGH as well, Hort General Hospital, where I'm working. And this is what we found, that it's occurring at a much younger age than internationally. The major proportion of our patients were between 30 to 45. So I would just as previously emphasize the same thing, the lifestyle changes that have to be implemented. But since we have the World Diabetes Day as well on 14th November, and we have a lot of talk shows and all that, if we could all join our hands to endorse and as well as augment the public service messages that are being given, perhaps we can give a list of points to be done. Walk this many steps a day, make these changes to your diet, and lose weight or maintain a healthy weight. Like we had it about contraception, do bache sehamand gharana. So perhaps we can emphasize kam vadan zyada than like ideal weight and a long lifespan. Something in Urdu that we can make it reach out to the people.
Yeah.
Yeah.
Excellent. I think what the other thing, I mean, we're obviously getting closer to the end, but once we're overcoming this pandemic, there is definitely a need in South Asia to make some, big, potential big public health changes. There's a big national diabetes prevention program going on in the UK. There's no reason why with better technology you couldn't do a prevention program just to motivate people not, to improve lifestyle, to delay getting diabetes for 5 to 10 years. Because even delaying diabetes for 5 years, instead of getting it at 35, getting it at 40 or 45, will give people lifestyle benefits. Because once the pandemic is gone, I'd be very happy to help you guys, if you, or the societies, I don't know, just to think about these things. And, you should definitely think about, what is it we can do as a nation that moves the agenda forward to try and get our community a bit healthier. But it's hard, because if the food environment is becoming more obesogenic, you're up against a really big battle. And,
I presented on that actually last year. There was this symposium and I presented in that. And it was about the diabetes prevention program in Pakistan. There isn't any, but you'd be amazed that there's a very good one in Sri Lanka. So if they can do it with the same kind of setup, and they had a very simple way of doing it, but there wasn't any in Pakistan, unfortunately. But I think, as you say, it's a good call to start it, and it'd be very nice with your collaboration if we could collaborate.
Yeah, no, I think it's doable. I think it's definitely doable, and it's
very good,
that could be a good starting point, because it's a really tangible test for people. Oh, wait a second, I'm at risk, and I can delay it with lifestyle. There's some real motivation to do something.
And we have a lot of pre-diabetics as well, which are undetected. So if we start routine screening as well, at least at the age of 45, as internationally recommended, perhaps we can make things better, rather at an earlier age in Pakistan, perhaps 40.
I agree.
I think probably at an earlier age, because we are seeing a lot of pre-diabetes and type 2 diabetes in younger kids as well. I see a lot of 12, 16.
We are seeing the double diabetes as well.
Yeah.
The type 1s with type 2 on top of it because of the obesity. Yeah, we're seeing that as well.
Kind of difficult, It's difficult to differentiate, many times.
Yeah. I mean, I think the way it should be done is, if certainly in the UK, we've got simple risk scores that can easily detect people at higher risk and lower risk, and then you can screen the people at the higher risk. Because if you screen everybody at 30 to 40, it's a lot of people to screen. But with a risk score, you could probably take the top 20% and do pilots and find out your screen detected rate, and then you cost effectiveness and all these things. But that could be done. There's lots of, and the risk score literally takes 30 seconds,
Zareen, do you have any questions at all, or any remarks, or any?
Hi, Assalamu alaikum. First of all, I would like to really appreciate Dr. Sattar for sharing your interesting facts related to South Asian obesity. And obviously, a lot have been discussed so far, and one important question as well as a comment has been discussed by Dr. Dugal as well, that the newer generation is coming up with a lower waist to hip ratio and taller heights, but I don't think that we're going to see this over here in South Asia, at least not to my experience so far. But you said that there is an intrauterine fact and some factors working there, and probably good nutrition would work for that. But I assume poor nutrition right from the start. You're very right that that may lead to obesity later in life. But what intervention can we really do at that level? And second point is related to Dr. Wadams. Thank you very much for sharing about different etiological factors about hypothalamic obesity. And here I'm seeing a lot of young children, school-going children, with coming up with obesity and marked acanthosis. And obviously, we have a lot to deal in with the lifestyle and the diet that we do, and we need a national level program for that. Unfortunately, we don't have it, because when you walk to, or rather when you drive to, or commute to your workplace in the morning in Pakistan, you see big billboards displaying large burgers, large cold drinks, attractive and fascinating with all those comments around it and young youth figures displaying how they love it and how yummy it is, McDonald's and everything. Sorry, I don't want to blame any brand, but this is a dilemma, as we have to deal a lot with the food industry actually, and this is our fight. I assume at national level, if we have to think about the nation and play our part as a nation, we have to fight the food industry really, rather than fighting with diabetes, obesity at our practice level, pragmatic level. But at the national level, we have a big fight waiting ahead. So I would take your comments on this. Thank you.
Heather, do you want to go ahead?
So on, I tend with families, I try to start with the family as one unit. So if I start inside the family home, I always ask all of the family members to eat the same food that the person who's struggling with obesity has to eat. So that anytime there's a restriction in snacks, or someone can have an Oreo, but you can't have an Oreo, it feels more like punishment. So I ask the whole family to take this journey together to support the one or two people who are struggling with weight. That's where I start in the family. I don't know how to tackle the national level, except maybe start raising the prices of McDonald's and start raising the prices of pop, and adding a tax to the pop and making it not as large. I think they got rid of supersize in America for this very reason. Actually, you can't supersize your meals anymore. It really needs to come at a national health level, and I guess pediatric adult endocrinologists are good lobbyists that could probably make that happen.
I agree about it, but I think raising the price that you mentioned, unfortunately, I don't know whether that would work, because people are happy to spend, for the food, I think. I may be biased on that, but.
Yeah. I notice here in this culture, everything comes by delivery. And, 11, 10, 9-year-olds are ordering off their cell phones, and it's attached to their parents' credit card.
Exactly.
So we really need to really have parental, and it has to be a family unit, really.
Yeah, no, I agree. I mean, I think it has to be family unit. I mean, these kind of conversations are happening in terms of the UK culture. So I was participated in some national questionnaires and policy discussions. How do we change the obesity environment in the UK? And, and for example, things like, as Heather mentioned, taxation on unhealthy foods and then making healthier foods more cost effective and less expensive. So the reality is the food industry has to be able to make a profit, but they need to also make better quality foods. And that's up to the government to really legislate to do that, because we can't do that. And it's not going to be easy. And another way to think about was to educate people about calories at schools. And maybe the best way to do it would be to put total calorie content on every food, including those in fast food outlets. And then people easily get it. Oh, wait a second. So if I had this burger and this Coke, that's what, 1,200 calories? Oh, wait a second. Maybe I won't have that just now. Maybe I'll go and have my banana and my cup of tea, which is 90 calories, and save my, do you know what I mean?
Yeah, I totally appreciate what you're saying. I'll give a personal story on that. I went to Five Guys. The burger was $5.50. The fries were $600, and my shake was $600.
Oh my God.
So now when I go to Five Guys, I just get a burger.
Yeah.
Yep. I had no idea.
Exactly. It changed your behavior, because suddenly you realize, that's almost 80% of my total daily intake for if you had all of it.
It is my total daily intake.
I think we are almost out of time. I think thank you a lot for wonderful talks, both of you guys, and thank you for the wonderful discussion by the panelists as well. I do feel that, in a resource poor country like Pakistan, moving forward, there is a big role of public health. just educating people, simple messages, simple, solutions, 1 or 2 steps. I think that's where things are, the way things are at this time in the country, already the prices are high for food. So I don't know, at this time, and a lot of time, food also becomes your reward or only comfort. So it's kind of a complex relationship and a complex situation.
You're completely
So,
correct. Yeah.
and plus, the level of education, and we have to see a big chunk of our population is also undernourished. So, the public health has to balance that and going forward, address that. And then comes the medication and then, the rest of the fancy stuff.
Well, the only positive is all of us will not be short of, patients and jobs, but
Unfortunately, yes.
and sadly, and COVID is only going to make it worse, I tell you.
Yeah, agreed.
Thank you all. Thank you all. It was
Pleasure.
great to have this kind of discussion. And thank you, Dr. Sattar and Dr. Wadams and all the panelists. And it's always lovely to hear you, Dr. Sattar and Dr. Wadams, for the first time. Yes, it was lovely. And I think with this, we can conclude the meeting. Yeah.
Okay. Thank you very much.
Thank you very much.
Bye-bye.
Thank you, everyone.
Bye.